Welcome to the Radon Smart Review GU Cancer Series.
Glad to be here.
So, did you know that for nearly a decade, the United States basically told men to just stop screening for the most common non-skin cancer in the world?
Yeah, all because of what was essentially a massive statistical illusion.
Right. It's wild to think about. But today, we are setting the agenda for a comprehensive masterclass covering localized prostate cancer.
Absolutely.
We're going to trace the complete patient journey for you, the resident preparing for the clinic, and, those oral boards.
Which is so crucial to get right.
Yeah, so we are starting upstream. We will look at screening, workup, and risk stratification, and then flow directly into the physics, the radiobiology, and the clinical decision-making of definitive EBRT dose and fractionation.
We definitely have a lot of ground to cover.
We really do, but by the end of this session, you will have a rock-solid framework for how to take a patient from an elevated blood test all the way to a definitive radiation treatment plan.
Exactly, because, the workup isn't just a formality you have to get through before you can design a treatment field.
Right.
It is the fundamental intellectual substrate that makes your risk stratification trustworthy.
Yeah, like if the screening is poorly applied at the population level, you get rampant overdiagnosis.
For sure.
Yeah.
And if the biopsy is poorly targeted by the urologist, you get severe undergrading.
Which changes everything.
Right. And if the genomic classifiers are misunderstood by the oncologist, you either overweight or underweight their contribution to the disease biology.
So we have to get the upstream data right before we can ever start talking about EBRT dose.
Absolutely. Because the dose is dictated entirely by the risk, and the risk is dictated entirely by the workup.
So let us anchor this right away with our first clinical case, because there's nothing like a real patient to make these abstract concepts tangible.
Let's do it.
Okay, picture this patient sitting in your consultation room. We have a 57-year-old man. He comes in with an elevated and rising PSA of 5.2. His DRE, the digital rectal exam, is completely normal.
Right.
He gets a multiparametric MRI, which shows a 1.2 centimeter PIRADS 4 lesion, and it's located in the right anterior transition zone.
Got it.
So when you are sitting in the hot seat across from an examiner, how should you present this case synthesis on your oral boards?
This is a 57-year-old man with an elevated and rising PSA who underwent multiparametric MRI showing a PIRADS 4 anterior transition zone lesion, followed by combined MRI targeted and systematic biopsy revealing grade group 2 in the targeted cores only. The systematic cores were benign, meaning that without MRI targeting, a standard 12-core TRUS biopsy would likely have missed this clinically significant cancer entirely, since the anterior transition zone is undersampled by systematic approaches. This case demonstrates three key workup principles. First, PSA screening detected the cancer before it was palpable. Second, MRI identified a lesion in a zone that systematic biopsy undersamples. Third, the combined targeted plus systematic approach provided the most complete sampling. Risk classification required the information from all three steps: PSA level, imaging findings, and biopsy pathology before any management discussion begins.
Man, I want to pause and really focus on the very first step of that clinical sequence because it sets off the entire cascade of events.
The screening.
Exactly. The PSA screening. I mean, our patient is 57 years old. Finding a grade group 2 cancer early in a man in his late 50s seems intuitively like a massive win for modern medicine.
You'd think so, right?
Yeah. But PSA screening has historically been one of the most viciously contentious topics in all of oncology.
Really has.
For years, the core argument has raged. Does widespread PSA screening actually reduce prostate cancer death? And, well, at what cost to the population?
It was a monumental controversy. It dominated urology and oncology for over 2 decades.
Right.
And to truly understand why the medical community was so fractured over a simple blood test, you have to understand the two landmark randomized control trials that framed the entire global debate.
The big ones.
Yeah. On one side of the Atlantic, we had the European trial, known as ERSPC.
Okay.
On the other side, we had the American trial, known as PLCO. And for years, these two massive, incredibly expensive trials seemed to give the medical community completely opposite answers.
Which is so confusing for a resident trying to learn this.
Exactly. So let's look at the European trial first. ERSPC randomized an astounding 162,000 men across several different countries in Europe.
That's a huge cohort.
Massive. And when they reached the 13-year follow-up mark, The data showed that screening produced a 21% relative reduction in prostate cancer, specific mortality, in their core age group of men aged 55 to 69.
Wow, 21%.
Yeah. The absolute risk reduction was roughly 0.7, one fewer deaths per 1,000 men screened. The headline published in the major medical journals was definitive. Screening saves lives.
But the underlying cost of saving those lives was astronomically high, wasn't it?
It was.
Because when you dig into the supplementary data of that trial, you find the concept of the number needed to screen and the number needed to diagnose.
Right, the collateral damage metrics.
Exactly. To prevent exactly one prostate cancer death, the number of men they needed to invite for screening was 570.
Which is a lot of blood tests.
And even more critically, the number of men they needed to formally diagnose with prostate cancer was 18.
Right.
That means 17 men are being handed a cancer diagnosis, potentially undergoing biopsies, dealing with the profound psychological burden of the C word,
Which is huge.
and possibly facing treatments that carry risks of incontinence and impotence for cancers that might never have actually harmed them in their natural lifetime.
Exactly. All that collateral damage just to save one single life.
But even with that high cost, the European trial showed a mortality benefit.
Right. It worked.
Then we crossed the Atlantic to look at the American trial, PLCO. This trial enrolled over 76,000 men.
Right.
And when their initial analysis was published, it sent shockwaves through the field because it showed absolutely no mortality benefit from screening. Zero.
The curves completely overlapped.
So I have to stand in for the resident here and ask, if the European trial was showing a clear, statistically significant benefit, why did the American medical establishment trust PLCO for so long?
It's a great question.
Why did highly educated oncologists and public health officials look at the PLCO data and conclude that screening was useless?
Well, the reason it was trusted so implicitly is because PLCO was a massive, federally funded, randomized controlled trial backed by the National Cancer Institute.
Right.
In the hierarchy of evidence-based medicine, we are trained to revere the large randomized controlled trial as the ultimate arbiter of truth.
The gold standard.
Exactly. But there was a fatal structural flaw in the execution of the American trial.
Oh, yeah.
And that flaw was catastrophic contamination in the control arm.
It's unbelievable when you read about it.
It really is. In a perfect trial, you have a screening arm where men get the PSA test and a control arm where men absolutely do not get the test.
Right, keep it clean.
But that is not what happened in America in the 1990s. In the group randomized to receive usual care, which was supposed to mean no routine screening, a staggering 40 to 52% of those men went out and got PSA screening on their own.
Just going rogue.
Exactly. They were going to their primary care doctors for a routine physical, and the doctor was drawing a PSA level as opportunistic screening, completely outside the purview of the trial protocol.
So PLCO was never actually a trial of screening versus no screening.
Never. Because of the behavior of the American healthcare system, it inadvertently became a trial of organized, systematic screening versus heavy, opportunistic, ad hoc screening.
When you really think about it, that is a mind-boggling amount of contamination.
It destroys a comparison.
If half of your control group is secretly receiving the intervention you were trying to test, of course your survival curves are going to overlap.
Right. You are comparing two groups of men who are largely doing the exact same thing.
So how did the oncology community finally pull themselves out of this confusion? Like, how did we reconcile two completely opposite narratives that were dictating the health policy of millions of men?
The reconciliation came through a brilliant piece of statistical detective work known as the Sodikoff reanalysis, which was published in 2017. Sodikoff and a team of collaborative researchers looked at the data and realized they could not take the trial arm assignments at face value.
Right.
They performed a highly complex modeling-based reanalysis that accounted for the actual documented rates of screening in both trials.
So smart.
Yeah. They stopped looking at what arm the men were randomized into and started looking at who actually got a needle in their arm to draw the blood.
That makes so much more sense.
Furthermore, they meticulously accounted for lead time bias.
Okay, let's pause and explain lead time bias because it is a concept that trips up a lot of residents on the boards.
Yes, please do.
Lead time bias is the illusion that a patient is living longer simply because you diagnosed their disease earlier.
Right.
So if a man has a tumor that is destined to kill him at age 70 and you wait until he has symptoms at age 68 to diagnose him, she lives for 2 years with the diagnosis.
Okay.
If you use a PSA test to find that exact same tumor at age 60, and he still dies at age 70, he has lived for 10 years with the diagnosis.
But he didn't actually live any longer.
Exactly. The screening did not extend his life by a single day. It just extended the amount of time he knew he had cancer. It is a statistical mirage.
Perfect explanation.
Yeah.
And when Sotokov's team adjusted the mathematical models to correct for that massive contamination in PLCO
Right.
and stripped away the illusion of lead time bias, the results of both the European and American trials miraculously aligned.
Wow.
The contradiction vanished. Both trials, when analyzed by what actually happened to the patients, showed an estimated 7 to 9% relative reduction in prostate cancer-specific mortality per year of mean lead time.
That's incredible.
They finally reconciled to show a clear, undeniable mortality benefit to screening.
Which brings us to the wild, whiplash-inducing ride of the USPSTF guidelines, the United States Preventative Services Task Force.
Oh boy.
Yeah. Back in 2012, they were looking primarily at that flawed, highly contaminated initial PLCO data.
Right.
Based on that, they gave PSA screening a grade D recommendation. They essentially broadcast a message to primary care doctors across the entire country to stop screening healthy men.
A total halt.
And the consequence of that nationwide moratorium was not just theoretical. We saw a measurable, real-world, terrifying rise in the incidence of regional and widely metastatic prostate cancer diagnoses in our clinics over the next several years.
That is devastating.
Men were showing up with bone pain instead of slightly elevated blood tests.
Yeah, we went backwards.
But then, as the European ERSPC data matured with longer follow-up, and as the Sotokov reanalysis exposed the truth about the American trial, the USPSTF had to reverse course.
They did?
In 2018, they moved away from the grade D and issued a grade C recommendation for men aged 55 to 69, emphasizing individualized, informed, shared decision-making.
That is correct. And the current urological and oncological specialty guidelines have formalized this approach, creating a much more nuanced landscape than the blunt instruments of the past.
Thank goodness.
Yeah, the American Urological Association, the AUA, and the Society of Urologic Oncology, the SUO, strongly encourage shared decision-making for men in that core age bracket of 55 to 69.
Right.
But importantly, they also emphasize having earlier screening conversations starting at age 40 to 45 for men who harbor high-risk factors.
That's a key distinction.
It is.
Huh.
This includes Black men who have a historically higher incidence and mortality from the disease, or men with a strong family history, or those carrying a BRCA2 genetic mutation.
What about NCCN?
Meanwhile, the NCCN guidelines recommend discussing the initiation of screening for an even broader age range, from 45 to 75.
Okay, that makes sense.
We also have critical biochemical refinements now. We do not just look at the raw PSA number in a vacuum anymore.
No, that's too simplistic.
Right. We use PSA density, which is the absolute PSA value divided by the physical volume of the prostate gland.
So why is that important?
Because a large, benignly enlarged prostate naturally produces more PSA, so the density helps us differentiate between benign prostatic hyperplasia and actual malignancy.
Right, right.
We also utilize the percentage of free PSA circulating in the blood. These adjunctive calculations are absolutely vital when we're trying to navigate the diagnostic gray zone, which is generally considered a PSA reading between 4 and 10 nanograms per milliliter.
Okay, so the screening mechanism is working properly again. We find the elevated blood test, and now we face the physical challenge of actually finding the tumor within the gland.
Yes, the imaging.
This brings us to the revolution of the MRI targeted biopsy. For you listening, multiparametric MRI, or MP-MRI, is the absolute standard of care.
Undeniably.
We are no longer flying blind. The multiparametric scan uses 3 distinct functional and anatomical sequences: T2 weighted imaging, diffusion weighted imaging, which we call DWI, and dynamic contrast enhancement, or DCE. Let's break down the underlying physics and biology of these scans. How are we mechanically spotting the tumor amidst the normal tissue?
Well, it requires understanding the distinct zonal anatomy of the prostate.
Okay.
On T2-weighted images, we are primarily evaluating the peripheral zone, which is the outer rim of the gland, where the vast majority of prostate cancers originate.
Right.
Normal, healthy peripheral zone tissue is rich in water and glandular fluid, so it appears bright or hyperintense on a T2 scan.
Okay, so it lights up.
Yes. Prostate cancer, on the other hand, disrupts that normal glandular architecture and replaces it with dense stroma and tumor cells, so it typically appears as a dark, hypointense focus against that normally bright background.
That makes sense.
However, the true workhorse sequence, the one that provides the most functional data, is DWI, diffusion-weighted imaging.
The crucial one.
Exactly. This sequence measures the random Brownian motion of water molecules within the tissue.
Oh, okay.
Yeah, because a prostate tumor is highly cellular, with cancer cells packed tightly together and very little extracellular space, the water molecules cannot move freely.
Right, they're trapped.
Exactly. This is called restricted diffusion. When the software translates this restricted movement onto the corresponding apparent diffusion coefficient map, known as the ADC map, the highly cellular cancer area appears very dark.
I love the classic mnemonic for this one, and it is something every resident should write down right now.
Oh, let's hear it.
Just remember the phrase, a dark cancer, ADC dark equals cancer on DWI.
That's perfect.
Yeah, it's a wonderfully simple board pearl that grounds the complex physics into an easy visual rule that will never steer you wrong under pressure.
So true.
And then we have the third sequence, the DCE. This sequence relies on the biological fact that tumors induce angiogenesis. They build their own chaotic, poorly formed blood supply. Because these tumor capillaries are leaky, the intravenous contrast material washes in rapidly and washes out rapidly compared to normal tissue, showing early, rapid enhancement.
Right, it's a very distinct pattern.
And all of these distinct imaging characteristics are fed into a standardized scoring system called PIRADS, which stands for Prostate Imaging Reporting and Data System.
Yep.
The score ranges from 1, which means clinically significant cancer is highly unlikely, all the way up to 5, which means clinically significant cancer is highly likely.
And in our case, Anchor, the patient had a PIRADS 4 lesion.
Right, meaning cancer is likely. But having a scan is one thing, proving it changes outcomes is another.
Always.
Let us look at the trial evidence that actually shifted our entire field's standard of practice toward MRI targeting. We have to walk through 3 specific trials: Precision, Adute, and CLOTS.
Let's start with the Precision trial. This was a massive, beautifully designed randomized trial that compared the new MRI-targeted biopsy approach directly against the historical gold standard.
Which was just the grid, right?
Right. The standard 12-core TRUS systematic biopsy, where the urologist essentially uses an ultrasound to guide needles in a predetermined geometric grid without actually seeing the tumor.
Just hoping to hit something.
Exactly. And the results of Precision were universally practice-changing. The group that received the MRI-targeted biopsies found significantly more clinically significant cancer, detecting it in 38% of men versus only 26% in the systematic group.
That is a big jump.
It is. But just as importantly, perhaps even more importantly for reducing overtreatment, the targeted approach found significantly less clinically insignificant low-grade cancer.
Oh, that's huge.
Yeah, it dropped the detection of insignificant disease to 9% compared to 22% in the systematic arm.
Wow.
It hit the absolute holy grail of cancer diagnostics. It found more of the dangerous disease that can kill you and less of the indolent noise that just causes anxiety.
Man, it sounds perfect. It sounds like we should completely abandon the blind systematic biopsies and only ever shoot for what we can see on the MRI.
You'd think so based on that alone.
Right, but then the Adute trial comes along and adds an incredibly crucial layer of complexity to the story.
Oh, it really does.
The researchers in the Adute study looked at combining MRI-targeted cores with the traditional systematic cores in the exact same patient during the same procedure.
Okay.
And they found that the combined biopsy approach actually upgraded the final pathological grade group in about 22% of patients compared to using systematic sampling alone.
Makes sense.
But here is the critical counterintuitive part that you must memorize. While the targeted cores successfully found dangerous cancers that the systematic grid missed entirely, the systematic cores also found about 9% of the high-grade grade group 3 to 5 cancers that the targeted cores completely missed.
That is wild.
Let that sink in. 9% of the most aggressive cancers were invisible to the targeted approach, but caught by the blind grid.
That is the pivotal takeaway for clinical practice. Targeted absolutely beats systematic if you are forced to choose, but combined beats either alone.
You need both.
Exactly. You need the targeted cores to hit the bullseye of the dominant lesion, but you need the systematic cores to sweep the rest of the gland for invisible satellite lesions or multifocal disease.
Totally.
And then we have the CLOTS trial, which addressed a different population. This trial showed that using MRI as a first step allows approximately one-third of men to avoid a biopsy altogether if their scan is completely negative,
That's fantastic.
while remaining statistically non-inferior for finding clinically significant cancer compared to biopsying everyone. It acts as a powerful triage tool to spare men unnecessary procedures.
I have to admit, when I first read the CLOTS data and looked at how good the MRI is at finding disease, I thought, great, we can just use these scans to monitor our active surveillance patients forever and completely skip the repeat biopsy needles.
A lot of people thought that.
But we cannot get overly confident in the scan alone, can we?
No, we definitely cannot.
There's a highly cited meta-analysis by Rajwa that looked specifically at using MRI for monitoring patients on active surveillance. It completely burst that bubble. What did that meta-analysis find?
It found that relying on MRI alone to monitor active surveillance misses 15 to 20% of actual pathological disease progression.
That's way too high.
It's unacceptably high. The sensitivity of a stable MRI predicting stable pathology was only 0.59.
Wow.
That means almost half the time, the cancer was quietly progressing under the microscope while the scan looked completely unchanged.
Terrifying.
So the MRI is a tremendously powerful adjunct, but it absolutely did not replace a confirmatory tissue biopsy.
Right.
You must never fall into the dangerous clinical trap of thinking a stable MRI guarantees stable pathology. The tissue remains the ultimate truth.
Okay, we have localized the tumor, biopsied it, and graded it. Let's transition logically into part 2, genomic classifiers and advanced staging.
Do it.
So the MRI tells us where the tumor is, and the biopsy tells us what it looks like under a microscope. But two tumors that look anatomically and histologically identical can behave completely differently in a patient's body.
Happens all the time.
Right. One might be indolent while the other aggressively metastasizes. To uncover that invisible intrinsic behavioral difference, we have to look at the tumor's genetic signature.
Yes.
If the workup so far has given us the standard clinical pathologic risk groups, what do the molecular and genomic tests actually add to our decision-making?
It's a key question.
The foundational principle I want to hammer home to every listener is this. Genomic tests refine, but they do not replace your established clinical pathologic risk groups.
That is exactly right. And the NCCN guidelines are explicitly clear on this hierarchy of information.
Good.
Your unbreakable foundation is the clinical T stage based on exam and imaging, the absolute PSA value, and the histological grade group from the biopsy.
You don't skip those.
Never. The genomic classifiers are brought in afterward to reduce the residual uncertainty within those predefined groups.
Right.
The predominant workhorse in our field right now is the Decipher test. Decipher is the 22-marker RNA expression assay.
Okay.
It looks at the RNA transcripts of genes involved in cell proliferation, cell structure, immune system modulation, and androgen signaling to generate a score representing the biological aggressiveness of the tumor.
And it's well validated, right?
Extremely well validated. It has been extensively validated across multiple clinical scenarios following radical prostatectomy, prior to definitive radiation, and during active surveillance.
Which trials should they know?
Seminal work by Spratt has shown that the Decipher score powerfully predicts the risk of developing distant metastasis independently of standard clinical features.
Awesome.
And research by Den demonstrated that it can effectively guide whether a high-risk post-prostatectomy patient needs immediate adjuvant radiation versus waiting for salvage radiation.
We also frequently utilize Oncotype DX genomic prostate score and Prolaris.
Yes, those are very common too.
We tend to use those mainly at the clinical crossroads of deciding between maintaining active surveillance and initiating definitive treatment for men who fall into the favorable risk categories.
Right, when you're on the fence.
They help tip the scales when the clinical data is borderline. But there is a massive structural limitation regarding the evidence base for all of these genomic classifiers that every resident needs to know cold for the oral boards.
Absolutely.
What is that limitation?
The critical limitation is that, to date, none of these genomic classifiers have been fully validated in prospective, randomized clinical utility trials, where the genomic score itself dictates the randomization and treatment assignment.
None of them.
None. Their entire evidence base currently relies on retrospective case cohort studies, analysis of archival tissue from older trials, and post-hoc statistical analyses.
Oh, wow, okay.
So while they undoubtedly provide highly predictive and clinically actionable information, they should never be used to unilaterally override a clear, unambiguous clinicopathologic risk group assignment.
That makes perfect
Right,
sense.
if a patient is high risk by traditional criteria, a low genomic score does not make them low risk. They are modifiers of the discussion, not the primary engine driving the treatment paradigm.
Let's expand our view from the molecular level to the whole body level and talk about staging, specifically the absolute revolution brought about by PSMA PET imaging.
Game changer.
PSMA stands for prostate-specific membrane antigen, which is a transmembrane protein highly overexpressed on the surface of prostate cancer cells. By attaching a radioactive isotope to a molecule that binds to this protein, we can literally light up the cancer anywhere in the body.
It's incredible technology.
It really is. We have the landmark PRO-PSMA trial published by Hoffman in 2020. This trial randomized high-risk prostate cancer patients to undergo standard conventional imaging with a CT scan of the abdomen and pelvis and a whole body bone scan versus undergoing a single PSMA PET scan. The results were staggering. The PET scan was 92% accurate for detecting nodal and metastatic disease, compared to a dismal 65% accuracy for conventional imaging.
The difference is night and day.
So let me push back here and ask the question every resident thinks about. If PSMA PET is that incredibly accurate, like if it is hitting 92% overall accuracy, why cannot we just skip the toxicity of elective nodal irradiation entirely if the PET scan is clean and negative in a high-risk patient?
I'm extremely glad you asked that, because this is perhaps the most classic oral board trap currently in circulation.
Oh, yeah.
You absolutely cannot skip elective nodal irradiation based solely on a negative PSMA PET scan.
Why not?
Because the sensitivity of PSMA PET specifically for detecting microscopic cancer in the pelvic lymph nodes is only about 40%.
Wait, really? Only 40%?
Only 40. Yes, it is vastly superior to a CT scan, which relies purely on a node being enlarged to over a centimeter to be called suspicious.
Right, CT is just looking at size.
Exactly. And yes, the PET scan's specificity is extremely high, hovering around 95%. That means if a node lights up on the scan, there is almost certainly cancer in that node.
Okay, that's good.
But the technology has a spatial resolution limit. It completely misses microscopic deposits of disease that are too small to generate a detectable radioactive signal.
Ah, I see.
In surgical series, PSMA PET missed more than half of the lymph nodes that were later proven to be pathologically positive under a microscope.
That is a staggering blind spot.
It is. So a negative scan emphatically does not mean negative nodes. You still absolutely require risk-based elective nodal coverage in your radiation fields based on the patient's underlying nomograms.
That is a critical practice-defining pearl. Do not let a highly specific modern scan lull you into a false sense of security regarding microscopic subclinical spread.
Exactly. We treat microscopic risk, not just macroscopic targets.
Right. And just briefly, to show the power of molecular imaging in a different setting, we should also mention the Empire 1 trial.
Yes, very important.
This trial utilized the fluciclovine PET scan to actively guide the design of salvage radiation treatment fields for men who were failing biochemically after surgery.
Right.
The trial showed an actual significant improvement in 4-year failure-free survival when the radiation fields were modified based on the PET findings.
Which is amazing.
We will explore the depths of salvage therapy in a later deep dive, but Empire 1 definitively proves that integrating molecular imaging into radiation planning directly changes patient outcomes.
It undeniably does.
With the workup and staging firmly established, let us logically shift gears into Part 3. Radiation therapy, radiobiology, and dose escalation.
The physics.
Yes, this is where the complex physics of the linear accelerator and the intrinsic biology of the tumor cell finally meet the clinic. Here is our second case anchor to set the stage.
All right, we have a 66-year-old man. He has NCCN unfavorable intermediate risk disease. His clinical stage is T2B. He has a PSA of 14, and his biopsy shows grade group 3. His multiparametric MRI identified a PIRADS5 lesion, but his staging PSMA PET scan shows completely negative lymph nodes.
Okay, pretty standard presentation.
All right, so he is sitting in your consultation room, he understands his diagnosis, and he asks you the ultimate therapeutic question. How much radiation dose do I actually need? And in how many daily fractions am I going to receive it?
That's the big one.
Exactly. How do you systematically formulate your clinical rationale for the examiner?
This is your 60-second board script for definitive EBRT dose and fractionation. You should read this verbatim on your test.
Let's hear it.
This is a 66-year-old man with unfavorable intermediate risk prostate cancer, 2 or more IRFS, T2B, and GG3 with high volume disease in 8 of 12 cores. He is a candidate for definitive EBRT with concurrent short course ADT covered in episode 6. The dose question has 2 layers. First, dose-escalated radiation, delivering 76 to 80 gray in conventional fractionation, clearly improves biochemical control compared to lower doses. And selected long-term datasets suggest reductions in distant metastasis and prostate cancer death in some settings, based on follow-up from MDACC and RTOG01COM6. Second, moderate hypofractionation, 60 gray in 20 fractions, 3 gray per fraction, is non-inferior to conventional dose-escalated regimens based on CHIP and ProFit, and is now recommended by consensus guidelines. The biologic rationale is the low alpha-beta ratio of prostate cancer, estimated at approximately 1.5 gray, which means larger fractions are radiobiologically favorable for tumor kill relative to late normal tissue effects. For boards, know the dose escalation evidence, know the 2 hypofractionation schedules with the largest evidentiary base, 60 gray in 20 or 70 gray in 28, and know that FLAME showed focal boost to MRI, visible lesions, improves biochemical control only when OAR constraints are prioritized.
Wow, yeah, that is a masterful synthesis.
It covers all the bases.
It really does. But to truly understand why we treat prostate cancer the way we do, we need to completely break down the underlying radiobiologic foundation you just mentioned. The alpha-beta ratio.
It's the core of everything we do.
It is. This mathematical concept is the entire reason prostate radiation fractionates differently than head and neck cancer or lung cancer. It is the heart of the linear quadratic model of radiation cell kill.
I find this concept is best explained through a vivid analogy.
Oh, analogies are great for this.
Think of a prostate cancer cell as a slow, lumbering, heavyweight boxer.
Okay, I like it.
Because prostate tumors generally have a very slow cellular proliferation rate, their alpha-beta ratio is extremely low, mathematically estimated at approximately 1.5 gray.
Right.
In the linear quadratic model, the alpha component represents unrepairable, lethal double-strand DNA breaks caused by a single hit, while the beta component represents sublethal damage that the cell can potentially repair if given time. Because our heavyweight prostate tumor is so slow to cycle and repair, he cannot recover quickly from massive heavy punches. Those heavy punches represent large daily radiation fraction sizes.
That paints a really clear picture.
Right. On the exact opposite end of the spectrum, the surrounding normal tissues that we are terrified of damaging, like the mucosal lining of your rectum and the wall of your bladder, are turning over constantly.
They're fast.
They are like quick, agile, lightweight fighters. They have a much higher alpha-beta ratio, typically estimated around 3 to 5 gray for late effects.
Right.
Because they are fast, they possess a robust capacity to repair sublethal DNA damage rapidly between small, daily rounds of radiation.
Which is what protects them.
Exactly. Therefore, if you change your strategy and start throwing fewer, much heavier punches, a strategy we call hypofractionation, you mathematically inflict exponentially more lethal damage on the slow-recovering heavyweight tumor than you do on the quick-recovering normal tissue. You manipulate the biology to widen your therapeutic window.
That is a brilliant and conceptually accurate way to visualize it. By increasing the dose per fraction, the therapeutic ratio inherently improves. The tumor suffers disproportionately more than the healthy organs.
Which is exactly what we want.
But before we fully embrace hypofractionation, we must acknowledge the historical foundation of dose escalation that made modern treatment possible.
No, for sure. We have to know where we came from.
Decades ago, in the era of early 3D CRT, we used to treat whole prostates to the high 60s or low 70s in terms of total gray.
Right.
We could not go higher without causing catastrophic rectal bleeding.
It was dangerous.
Very.
Yeah.
But as imaging and targeting improved, multiple phase 3 randomized trials proved that pushing to higher total doses, specifically up to 76 to 80 gray, in conventional small daily fractions, dramatically improved biochemical control by 15 to 20%.
Right. The most famous example is the MDACC trial, spearheaded by Pollack and Kuban at MD Anderson.
A classic.
They randomized men to receive either 68 gray or 78 gray. When they published their 20-year follow-up, the results were astounding.
What do they find?
Not only was biochemical control vastly, undeniably improved in the higher dose arm, but they actually saw a numerical reduction in distant metastasis, dropping from 4% down to 1%, and a halving of prostate cancer-specific mortality, dropping from 10% down to 5%.
That's incredible long-term data.
It is. Escaping the prostate bed clearly prevented systemic failure decades later. Then we have the massive cooperative group confirmation from the RTOG 0126 trial.
Right, another huge one.
This trial looked at standard dose, 70.2 gray, versus escalated dose, 79.2 gray. At 15 years of follow-up, dose escalation once again definitively improved biochemical control and reduced the rate of distant metastasis.
Consistent results.
Yeah, but the RTOG 0126 trial is also incredibly important for what it taught us about physics, technology, and toxicity, isn't it?
Oh, absolutely. Yes, it is the trial that essentially proved the modern necessity of utilizing IMRT, intensity-modulated radiation therapy.
How did that happen?
Well, halfway through the trial, they realized the toxicity from 3D conformal fields was too high, so they allowed IMRT as an allowed amendment.
Ah, they had to pivot.
Exactly. The subsequent analysis showed that using IMRT, which uses inverse computer planning, and moving multi-leaf collimators to physically carve the high-dose radiation cloud tightly around the prostate and away from the rectum.
It's like sculpting the radiation.
Right. It clearly reduced acute and late gastrointestinal and genitourinary toxicities compared to older, blockier 3D techniques.
That makes total sense.
Furthermore, they generated the critical foundational dosimetric constraint that every planner uses today. They proved mathematically that keeping the volume of the rectum receiving 70 gray, the V70 metric, to less than 15% of the total rectal volume is absolutely vital to preventing grade 2 or higher late rectal toxicity, like severe bleeding and fibrosis.
That 15% threshold is burned into every resident's brain.
As it should be.
And to round out the dose escalation story, we also have to mention the relatively recent GETUG 18 data out of France.
Yes, very compelling data.
This trial specifically looked at high-risk patients who were concurrently receiving long-term androgen deprivation therapy, or ADT.
Right.
They compared treating the prostate to 70 gray versus pushing it to 80 gray. The long-term data revealed a statistically significant overall survival benefit in the high-dose 80 gray arm.
Overall survival, that's the ultimate endpoint.
It is a striking, definitive finding that completely cements the absolute need for aggressive, escalated radiation dosing in high-risk disease, even when you are employing long-term systemic hormone suppression.
Right. The hormones do not replace the local radiation dose.
Exactly. Which brings us perfectly to part 4. Moderate hypofractionation and focal boost.
Let's get into it.
We have established we unequivocally need a high biological dose to kill the cancer. But given the heavyweight boxer radiobiology we just discussed, do we really need to drag patients in for 40 daily treatments over 8 long weeks?
It's a huge burden on the patient.
Right. Can we deliver that high biological dose in fewer, larger fractions?
The answer is an emphatic yes. And moderate hypofractionation is considered the absolute standard of care today.
Excellent.
The two anchor trials that define this modern era are CHIP, spelled C-H-H-I-P, and ProFit. Let us examine the CHIP trial first.
Okay, what did they do?
This was a massive multi-center trial conducted in the United Kingdom. They took their standard conventional arm, which was 74 gray, delivered in 37 fractions, and tested it against 2 different experimental hypofractionated arms.
What were the results?
Well, the arm receiving 60 gray delivered in 20 fractions of 3 grays each was definitively proven to be non-inferior for biochemical control.
That's great.
However, and this is crucial, their lowest dose arm, which delivered 57 grays in 19 fractions, was not non-inferior. It statistically failed.
Oh, wow.
It was too biologically cold. So 60 grays and 20 fractions emerged as the precise evidence-based sweet spot.
Then we have the ProFit trial, which many statisticians argue is arguably the cleanest, most rigorously designed non-inferiority trial we have in the literature.
It's a beautiful trial.
They compared an already modern dose-escalated control arm of 78 grays in 39 fractions directly against the experimental 60 gray in 20 fractions arm.
A true head-to-head.
And the hypofractionated arm hit the non-inferiority margin perfectly, maintaining excellent cancer control with absolutely no increase in acute or late toxicity. toxicity.
Just phenomenal results.
We also have the RTOG0415 trial, which successfully validated a slightly different schedule of 70 gray delivered in 28 fractions, specifically for low-risk men.
Also good to know.
But while the math seems highly favorable, there are serious cautionary tales here, aren't there? We cannot just pull out a calculator, plug in the alpha-beta equation, and make up any extreme hypofractionation schedule we want.
No, absolutely not. The biology will punish you if you get it wrong.
Right.
And the HYPRO trial is the perfect example of hubris in radiation oncology.
What happened there?
The investigators in the HYPRO trial tried to prove actual superiority over conventional fractionation by using an aggressive schedule of 64.6 gray delivered in just 19 fractions.
Wait, 19 fractions?
Yes, that is 3.4 gray per day. The trial completely failed to show any superiority for cancer control, but tragically it caused significantly higher rates of severe late genitourinary toxicity.
That's awful. Why did it fail so badly?
Because the calculated biologically effective dose, the BED, was simply pushed too high for the normal bladder, neck, and urethra to tolerate. They exceeded the repair capacity of the normal tissue.
The lightweight fighters couldn't recover.
Exactly. We also have very soberest data from Fox Chase Cancer Center. They carefully analyzed their hypofractionation cohorts and found a clear clinical warning sign.
What was it?
If a patient comes into your clinic with poor baseline urinary function, which they defined as an International Prostate Symptom Score, an IPSS score greater than 12, utilizing hypofractionation led to significantly worse late GU toxicity compared to conventional fractionation.
Ah, so their baseline matters.
Greatly. A bladder that is already struggling with benign hyperplasia cannot handle the heavy punches. You have to counsel those specific patients very carefully and often revert to conventional 8-week fractionation to protect their quality of life.
Now, let's move to the cutting edge of treatment planning. The FLAME concept.
This is exciting stuff.
It's a conceptually fascinating approach because modern multiparametric MRI shows us exactly where the dominant, highest-grade intraprostatic lesion is hiding. The designers of the FLAME trial asked a bold question. Instead of treating the entire gland the exact same uniform dose, can we use IMRT to paint a focal, simultaneous integrated boost, an SIB, delivering a massive dose exclusively to that specific MRI-visible lesion?
Just blasting the main tumor.
Exactly. They randomized patients to receive a standard 77 gray to the whole prostate versus the same whole gland dose, plus an SID, pushing the dose up to an incredible 95 gray, squarely on that targeted lesion.
95 gray.
Historically, radiation oncologists were terrified of going anywhere near 95 gray because of the extreme risk of causing fistulas or burning a necrotic hole in the urethra.
It sounds incredibly risky.
Right. So what actually happened when they ran the trial?
It was a resounding success that shifted the paradigm. The addition of the focal boost significantly improved 5-year biochemical disease-free survival, raising it from 85% in the standard arm up to 92% in the boosted arm.
That's a solid improvement.
And they did it without causing the catastrophic toxicity everyone feared.
Wow.
Well, this is the most critical, non-negotiable part of the entire trial design. They achieved those safety outcomes by following an absolute golden rule. The dose constraints for the organs at risk, the OAR constraints, were considered sacrosanct.
Unbreakable rules.
Unbreakable. They strictly required the urethral D 0.1 cc to stay strictly below 80 gray, and the bladder wall D 2 cc to stay strictly below 80 gray.
Okay.
If a patient's specific anatomy meant that forcing the tumor boost up to 95 gray would mathematically violate those normal tissue constraints, the dosimetrists simply reduced the boost dose until the organs were safe.
That is the ultimate profound takeaway for clinical practice right there. The safety of the organs at risk must take absolute priority over your ambition to escalate the tumor boost.
Every single time.
If the multiparametric MRI shows that the dominant tumor is anatomically wrapped tightly around the urethra, you do not force the computer to paint 95 gray over it. You protect the urethra first, accept a slightly lower boost dose, and preserve the patient's ability to urinate normally. Okay, we have covered a massive amount of incredibly dense biological and clinical ground.
You really have.
Let us move to Part 5, Board Blitz and Oral Board Traps. We are going to explicitly go over the specific common traps that examinees fall into when sitting across from their examiners, and then hit a rapid-fire Q&A to test your recall.
All right, trap number one is casually citing the American PLCO trial as definitive evidence against PSA screening without ever mentioning the profound contamination issue.
Such a common mistake.
It is. If you
Yeah.
sit there and just say PLCO was negative, so screening is controversial, the examiner immediately knows you do not actually understand the historical literature.
Right, you're just parroting headlines.
Exactly. You must explicitly mention the 40 to 52% contamination rate in the control arm and confidently cite the Sodakov reanalysis that reconciled the global data.
Trap number 2. Relying on MR-targeted biopsy results alone without acknowledging the necessity of the systematic cores. If you present a case and say, the urologist successfully targeted the PIRADS 5 lesion, so we do not need the rest of the gland sample to know his risk, you will fail that station.
Instantly.
You must proactively cite the E02 trial data demonstrating that you will completely miss 9% of the most aggressive, high-grade cancers if you abandon the systematic template approach.
Absolutely. Trap number 3. Improperly using genomic classifiers to override hard clinico-pathologic risk groups.
We talked about this.
Yeah, if a patient is clinically categorized as high risk by standard NCCN criteria due to a high PSA or aggressive biopsy grading, but his Decipher score comes back unexpectedly low.
You don't just ignore the clinical data.
No, you do not suddenly treat him like a low-risk patient and recommend active surveillance. The genomic scores refine your adjuvant discussions. They absolutely do not replace the primary clinical staging.
And trap number 4 is exactly what we just discussed with the physics planning. Attempting to boost the MRI visible lesion to 95 gray without explicitly respecting the strict OAR constraints.
Crucial point.
The investigators in the FLAME trial prioritized the safety of the urethra and the anterior rectal wall above the cancer control of the tumor boost. As a safe practicing oncologist, you must demonstrate to the examiner that you will do the exact same thing.
Spot on.
All right, are you ready for a quick board blitz? I am going to ask the clinical questions. You provide the definitive answers and the underlying rationale.
Let's do it.
Question 1. A 60-year-old man has a highly suspicious PIRADS 5 lesion on his MRI. His urologist performs a strictly targeted biopsy only, skipping the grid entirely, which shows a moderate grade group 2 cancer. What is the fundamental clinical limitation of this specific approach?
The profound limitation is that a targeted biopsy performed in isolation misses clinically significant, potentially lethal cancer located in the non-targeted regions of the prostate. The clinical rationale is anchored by the E02 data, which definitively prove that approximately 9% of high-grade dangerous cancers are found exclusively within the blind systematic cores. You inherently need the combined, targeted, and systematic approach to accurately risk stratify the entire gland.
Excellent synthesis. Question 2. A 63-year-old man is newly diagnosed with NCCN high-risk disease. He undergoes a PSMA PET scan for advanced staging.
Okay.
The scan shows a solitary right obturator lymph node lighting up brightly. Based on current data, what is the actual sensitivity of PSMA PET for detecting malignant pelvic nodes in the primary staging setting?
The sensitivity is surprisingly low, only approximately 40%.
Wow, yeah.
Conversely, the specificity is incredibly high, well over 90%. Therefore, if the node is actively lighting up on the scan, the finding is real and represents macroscopic metastasis.
Makes sense.
But crucially, the low sensitivity means a completely negative scan does not effectively rule out the presence of microscopic subclinical disease. You must still routinely irradiate the elective pelvic nodal basins in all high-risk patients, regardless of a negative PET scan.
Exactly right. Never trust a negative scan over high-risk biology.
Never.
Final question. Question 3. You are evaluating a favorable intermediate risk patient in the clinic who is planned for moderate hyperfractionation. Of the major trials, which specific regimen possesses the strongest, cleanest non-inferiority data against a modern, already dose-escalated control arm?
The definitive answer is the schedule of 60 gray delivered in 20 daily fractions.
And where does that come from?
The rationale comes directly from the Canadian ProFit trial, which was impeccably designed. It compared 60 grays in 20 fractions directly against a highly modern, fully dose-escalated control arm of 78 grays in 39 fractions, and successfully proved statistical non-inferiority for biochemical control, with absolutely no corresponding increase in long-term toxicity.
Fantastic work. Let us collaboratively recap this incredible, complex patient pathway we have just mapped out over the course of this masterclass.
Sounds good.
It all originates upstream with PSA screening. The historical data, when properly and rigorously analyzed to account for real-world behavior, demonstrates that screening absolutely works to reduce cancer-specific mortality.
It does.
But that biological success requires us, as responsible clinicians, to use highly intelligent, nuanced downstream management to actively avoid the catastrophic pitfalls of overdiagnosis and overtreatment.
That is exactly the right perspective. And that intelligent downstream management mandates, using the multiparametric MRI, combined with a targeted and systematic biopsy as our absolute gold standard diagnostic tool.
The ultimate combo.
Right, the MRI targeting reliably finds the most dangerous dominant cancers, and the systematic cores act as a critical safety net to catch the multifocal disease that the MRI inherently misses.
Okay.
From there, we integrate genomic classifiers like Decipher and advanced molecular imaging like PSMA PET as profoundly powerful adjuncts to refine our understanding of the staging.
But we never allow them to completely replace our foundational core clinical logic.
Exactly.
And finally, when that patient arrives at the linear accelerator for definitive EBRT, we know beyond a shadow of a doubt that total dose matters.
Yes.
We must escalate the dose to the high 70s or 80 gray if we are utilizing conventional small daily fractions. But beautifully, thanks to the unique, slow, heavyweight boxer radiobiology of prostate cancer cells, we can safely and effectively utilize moderate hyperfractionation, specifically the 60 gray and 20 fractions regimen as our standard, highly effective clinical workhorse.
It's just so much better for the patient.
Right. And if the patient's specific internal anatomy allows and the rigid OAR constraints protecting the urethra and rectum are strictly respected, employing a focal, simultaneous, integrated flame-style boost can further improve their biochemical control without ruining their quality of life.
You truly have the complete panoramic picture now. From the primary care doctor's initial blood draw, through the complexities of the biopsy pathology, all the way to the final computer-generated physics plan on the treatment console.
It's quite the journey.
It is, and this is exactly how you safely and expertly master the management of localized prostate cancer.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.